Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Now we are continuing for the final year Mbbs students or third year Mbbs students and some of the fellows who are interested to listen this lecture or tutorial type of presentation for the Pakistan, specifically for Pakistan actually, and who are entering the different zones of the examination. And previously, actually, I am continuing it. I have already said something about in the nephrology are concerned, you should know the interpretation of the renal function tests, specifically speaking about the urine RE interpretation. Then we have done the acute renal failure, perirenal, renal and post-renal. And then we have done the chronic renal failure, including the uremia, which is a very long topic. And afterwards I want to continue with it. That is the nephrotic syndrome for the final year Mbbs students of Pakistan. I am Professor Syed Ali Haider. I am visiting professor of the medicine, Jinnah Sindh Medical University. What is nephrotic syndrome? You don't know what is nephron. It's different parts, the glomerulus and the systems which we have got. The proximal tubules and the distal tubule, and there is, between this there is a loop of Henle, and then collecting ducts, and collecting at the pyramids and forming the major ducts, and then aggregate to form what is called the pelvis of the ureter, downgoing the ureter. The nephron means basically the unit, it is a basic unit of the kidney, or most functional unit of the kidney, nephron. So it is a part of this, we are saying that it consists of the glomerulus, basically. Now it's focusing on the glomerulus now. It means it is a glomerular type of the disease, whether it is directly or indirectly involving the nephron. So if the nephron function is filtration, and different parts of the nephron you know about it, the basement membrane, the other parts, the pores are in it and so on. Accordingly, they are filtering it when a specific pressure is created, while the systemic arterial pressure at 1200 ml of the blood is coming into a kidneys bilaterally. Actually 600 ml per cycle of the cardiac is distributed to the kidneys. So they are filtering and specific substances, and they are excreted out in the proximal convoluted tubule, the loop of Henle, the distal convoluted tubules, and the collecting ducts. Now, up till here, we will say that it is the injury actually of the glomerulus which could cause the problem of filtration. To diagnose it, the essential of diagnosis, essentials. Number one is the proteinuria. The protein which are excreting out into the urine for any person is very, very small amount. Because it is a bodybuilding part, it should be definitely reabsorbed. If it is filtered out, it is reabsorbed. So it is not coming into the collecting duct, it means that. And in the urine examination, you will find 10 to 20 milligram of the protein in the 24-hour urinary output. Now, proteinuria may be possibility with a normal person, of course. What is we know, understand is up to 50 milligram because of the age is also causing the degenerative process. It is in somebody or some books on some nephrologists say that 30 milligram to 30 milligram is normal, no problem. And some workers they said that 50 milligram is normal. So afterwards, more than 50 milligram, it is not normal. For example, it is between 50 to 100 milligram. It is a mild proteinuria. And it is a mild proteinuria usually seen in physiological state, like for example, exercise, stresses, high-grade fevers, after prolonged standing, pregnancy. You see this type of proteinuria. People do come us with a protein positive. In 24-hour collection, it is 100, 120 milligram, 130 milligram. 24 hours means that it is benign type of the proteinuria. So it is between the 50 milligram to the 300 milligram, what we call as the microalbuminuria, because albumin is the main protein. Between this, it is called the microalbuminuria. Then afterwards coming to the more than that, it is called 300 milligram upwards. Let's come to the, for example, it is more than 300 milligram and it is about 500 milligram per 24 hours. It is a macroalbuminuria or macroproteinuria. After 500 milligram, if the protein is excreting, but less than it is 3 gram or 3000 milligram or 3500 milligram, it is what is called subnephrotic type of proteinuria, because afterward it is called frank proteinuria. The frank proteinuria is divided into this, which I said that if it is less than 3.5 gram per 24 hours, it is subnephrotic proteinuria. After 3.5 gram per 24 hours, it is called massive proteinuria, and this is what is called nephrotic type of proteinuria. So proteinuria may be possibility of the normal variant, or it may be microalbuminuria, it may be macroalbuminuria, it may be frank proteinuria, it may be possibility of subnephrotic type of proteinuria, or it may be nephrotic type of proteinuria. So glomerular damage will cause this. Of course, this is a major part. First thing is that the proteinuria should be there. It is more than 3.5 gram per day. The 24-hour collection of the protein will be advised for this patient. And protein to creatinine ratio, if you will do this, it is more than 3 to 3.5, which you usually will not do, because depending upon it is the protein to creatinine ratio, urinary protein to the protein. Urinary creatinine ratio is more than 3 to 3.5. Because it is excreting out, there will be hypoalbuminemia, which would be 1.5 to 3.5 is normal value, which is less than 3 gram per liter in the serum. Definitely. It is the second part of the essential of diagnosis. The third part of essential of diagnosis is the because oncotic pressure is decreased in this way. It is dependent on the presence of the proteins. It will cause an Osaka or generalized edema. So these are the three essentials of diagnosis you have to prove before going for the nephrotic syndrome. The major part is proteinuria, then followed by the hypoalbuminemia, and third is this. Adjacent to it, the other rings you can make. Three are the essentials. Lipid urea and the hyperlipidemia or dyslipidemia is also will be there. Lipids are also excreting in it, as well as there is high triglyceride levels and high LDL levels will be found in this condition. Although these are not necessary essentials of the diagnosis. And this is what is I said that this is the excretion of the nephron, which is seen here, and damage will cause proteinuria. You see the endothelial cell fenestration too small for the albumin to pass through, it becomes enlarged and it will come out in the proximal convoluted tubule. Around it the Bowman's space is there, and there will be basement membrane with the negative charge that repels the albumin also negatively charged. So repulsion occurs, and in this fashion the albumin will not be able to come out in the proximal convoluted tubule. So it means that if this is disturbed, the glomerular basement membrane and these pores and the Bowman's space and podocytes along with it, if they are disturbed or damaged, then it will release the protein into the urine. Simple as that. The etiology of this condition is primary glomerulopathies, primary or idiopathic mostly. Minimal change disease or minimal change glomerulonephritis, which is most commonly seen in the children. And then this membranous nephropathy or membranous glomerulonephritis, mostly common seen in the adults. Focal and segmental glomerular sclerosis, FSGS, and membranous-proliferative glomerulonephritis. These are the primary glomerular diseases or primary glomerulonephritis. Secondary glomerulopathies are diabetes mellitus, the leading cause of the secondary nephrotic syndrome, leading cause. It will damage the nephron in many ways. Systemic erythematosus, that is autoimmune disease. Amyloidosis, which is a degenerative process where the amyloid proteins are depositing. It may be primary, it may be secondary. Infection like hepatitis B and C and HIV, syphilis, those are streptococcal, will cause this damage to the glomerulus. And a malignancy like multiple myeloma, which is one of the lymphoma and Hodgkin's lymphoma and solid tumor, will cause the effect by the substances of the, it is called a paraneoplastic type of effect on the kidneys, and it causes proteinuria, massive proteinuria. Drugs like NSAIDs, gold, penicillamine, heavy metal, etc., they will also cause damage to the glomerulus. Although they are NSAIDs causing the interstitial nephritis or an analgesic nephropathy, but glomerulus is also involved. The clinical presentation in this, because usually seen in the younger age groups rather than in the older age groups. Generalized edema, nasarga, the predominant feature of the face particularly is involved first, then. That is periorbital area is swollen in the morning and then it comes to the lower extremities and genital area, and in the day, hydrocele can be seen along with it. In advanced disease, the whole body is involved with the edema, that is called anasarca. Anasarca is the accumulation of the excessive amount of the fluid in the internal environment. That is the extracellular spaces, and it will lead to the shortness of the breath because the lungs are also involved. Directly the picture is seen, leakage is occurring in the lungs. It will cause the shortness of the breath. There will be frothy urine, and the urine deficit proteinuria value of 3 positive, like this type of the urine. जैसे चावल का पानी होता है ना, उस टाइप का ये हो जाता है. हमें समझने को कहेगा जी मैंने जब पेशाब किया ऐसा लगा कि चावल को निथारते हैं जब आप, उसका जो पानी होता है गद्दा सा पानी होता है, वो वाला सीन होता है इसमें ज़्यादातर. सिम्टम एंड साइन फॉर द सेकेंडरी कॉज इज प्रेजेंट. अगर डायबिटीज़ है, अगर किसी एसिडी है, तो उसके अपने फीचर से हम पकड़ लेते हैं. दिस इज द कॉज ऑफ द मैसिव प्रोटीनुरिया of nephrotic level. Diagnostic workup is that first go to confirm the clinical diagnosis. You have to collect the urine 24 hours for the protein 3.5 gram. This is nephrotic range proteinuria. Alternative to the total protein to creatinine ratio. On the random urine sample, if it is not possible for the collection for 24 hours, then total protein in the urine to the creatinine ratio will be, it is again more than 3.5, 3 to 3.5. It is a random sample. Second goal, to seek a possible cause. The history and physical examination. The systemic diseases, take the history properly. What happening? What is happening in serological studies after we do the ANA, complement, hepatitis B and C, serologies, and the measurement of the cryoglobulins. Because hepatitis C will cause the miscryoglobulin, and it can cause the glomerulonephritis, serum or urine protein electrophoresis for the multiple myeloma and other conditions related to it. Renal biopsy is the gold standard method to seek the possible cause. Third goal, to assess the renal function, you will go for the blood urea nitrogen, serum creatinine clearance, how much is GFR, sodium, potassium, bicarbonate, chloride, electrolyte should be done. Fourth goal is to identify the biochemical disorders related to the nephrotic state, biochemical, like blood CBC, serum albumin, total proteins, serum calcium, lipid profile, coagulation test. I will also do the serum TSH. Now, indication of the renal biopsy, the adults renal biopsy is mandatory for every nephrotic syndrome. Except the diabetic patient, you know the diabetes will cause nephrotic syndrome. If it is non-diabetic, and you see in the case in the adults, and the only diagnosis possible, you have to do the renal biopsy. And in children, actually, because in 90 to 95% of cases, it is minimal change in glomerulonephritis, which is primary glomerulonephritis, and you will go for directly the glucocorticoid therapy. And the renal biopsy afterwards will be taken out. Only for the glucocorticoid resistant, if it is not responding, then do the biopsy. In children, it means that. Otherwise, it is the minimal change glomerulonephritis. In diabetic patients, only is needed when 10% of nephrotic syndrome cases in diabetes are due to the other renal disease. Because other renal diseases are also associated with the diabetes. You go for the This is the normal kidney biopsy which is shown here. So see this on this sample, this sample, this sample. All the glomerulus, the high magnifying field. More than this is the micrograph, electromicrograph. And minimal changes you find, that is the loss of the food processes. Because it is in the biopsy, no change is seen. If you high power field, you will find this. That is, with the normal basement membrane, and food processes are blunted, are gone of this epithelium. And that is the only change we see. That is what it is called the minimal change disease, MCD. In the membranous glomerulopathy, what happens is, in the micrographs of 500 feet or more than one, you can find this, the formation of the thickened basement membrane. And this is the diagnostic point, and there is subepithelial deposits are seen underneath if it is electromicrography. Otherwise, you see that this basement membrane is thickened membrane in a minimal change nephropathy. Focal and segmental glomerular sclerosis in the different parts, in the segments, and in the different segment, in one segment there only the portions are involved in this condition, and there is again the basement membrane will be thickened out, and there will be sclerotic changes are seen. Fibroblasts are collected in and around this glomerular basement membrane. Membranoproliferative glomerulonephritis you see in this condition. In type 1 and type 2, both are there, and you find in this condition actually the membrane which is thickened with proliferation of the glomerular cells are visible in this condition. Interposed mesenchymal cell processes, submenstrual deposits are seen in this condition. Basic concept is this. Renal biopsy results is shown. I have said that in minimal change disease there will be normal in the low micrograph, and electromicrography you will find the food process fusion, because nephron is normal in the routine micrography. But it will only be possible to see the loss of food processes, high magnifying field, or in the electron microscope. In the light microscopy, in the minimal change, you find the thickening of the basement membrane, or in the electron micrograph, you find the subepithelial deposits of IgG. Focal and segmental glomerular local, it is light microscopy, focal and segmental sclerosis, meaning fibrosis in the glomerulus. But in electron micrograph, you find the focal and diffuse food process effacement. In the membranoproliferative glomerular lower, the light microscopy, there will be thickening of the capillary wall plus cellular proliferation. And in electron microscopy, you find the double contour or a tram track appearance and present the interposition of the mesangial cells. It is also mesangial cell glomerulonephritis. So it is membranoproliferative glomerulonephritis, also called mesangial cell glomerulonephritis. Interposition of the mesangial cell with the glomerular basement membrane. If it is subendothelial, it is called type 1. Intramembranous, it is type 2. Whatever is type 1 or type 2 will cause the nephrotic syndrome. Complications due to the reduced oncotic pressure, loss of the proteins. It will cause the hyperlipidemia, and it will cause hypovolemia, acute renal failure, and sarca, and the risk of cellulitis, bacterial peritonitis, ascites, large pleural effusion, pulmonary edema symptoms may be appearing. Because oncologic pressure is reduced, the fluid will come out from the cell, from the intracellular to the extracellular compartment. Due to the loss of the protein in the urine, you are losing the proteins. What will happen in this condition is this, that you are losing every type of protein, whether it is immunoglobulin. If it is immunoglobulin, then susceptibility to infections are more, antithrombin 3 is lost. Naturally, it is a coagulant which is present, and proteins. Remember that the protein C and S is also involved because it is natural anticoagulant which is present in the serum. It will cause the thromboembolism, and it is a very important complication. Vitamin D binding protein is lost, which causes vitamin D deficiency. Transfer will cause iron deficiency, and thyroid, binding proteins, hormone binding proteins will cause hypothyroidism. In the same patient, the other protein which are necessary for the binding will also be lost. The growth hormone needs the protein binding, and the corticosteroid hormone also will be there. Although they are these are of the least effects in this disease, but other than that, the thromboembolism and the hypothyroidism we have picked many cases. Treatment is symptomatic, basically, or treatment of the complication, and the disease is specific. There are 3 types of the management. Edema, low salt fluid, diuretics, serial measurements of the body weight. Daily weight will be lost. You give furosemide, that is loop diuretic, so much urine output is more and more. In this way, the proteinuria, to inhibit proteinuria, the only thing you use is ACE inhibitors or the angiotensin receptor blockers are good in the reduction of proteinuria. About hypoalbuminemia is concerned, high protein diet not indicated. Protein, remember, in the urine, if it is coming, it is the most injurious substance. So, although hypoalbuminemia is there, you will give the low protein diet to this patient. Although, because it is naturally, if you address the specific conditions, the etiology, then the hypoalbuminemia will be reduced. The hyperlipidemia, regular lipid profile, statins, if severe long-lasting nephrotic syndrome, you have to give it. Or you have to give the fibrates, control other cardiovascular risk factors, target the blood pressure, so 125 or 575. Although in this condition, the BP is normal. Thromboembolic risk, routine prophylactic anticoagulation, which is not recommended if it is high index and there is past history of coagulopathy. Then you give the prophylactic anticoagulation, warfarin, for example. Infections are more commonly seen because loss of the IgG, high index of suspicion of, if this is there, and anti-pneumococcal and influenza vaccination should be done in this patient. Capsulated organisms, against capsulated organisms. In the disease-specific therapy, you will go for the minimal change disease. The only thing, first of all, you use the steroid. If it is steroid resistant, then you give the second trial of the steroids. 3 relapses per year, or 2 relapses per year, for example. You have to give the high dose and then taper it off in 3 months. Definitely this disease will be inhibited. Otherwise, second cycle of the steroid should be given, or third cycle. Up to third cycle, you can give. Otherwise, you have to go for the other measurements because it is also autoimmune type of a nature of disease. Some study shows that if you give the immunosuppression, then it may be beneficial. Membranous nephropathy is concerned, it is generally a good outcome, and you can give in this condition glucocorticoids along with immunosuppression, for example, prolambucil or cyclophosphamide for 6 to 12 months. If it is non-respondent, then cyclosporine should be tried for the 12 months, 1 year. For the focal and segmental, again the same, it is autoimmune in nature, but the prednisolone is not to be effective. It may reduce the proteinuria and slow progression only. It is not a good outcome of the disease. The resistant cases may respond to the glucocorticoids along with the immunosuppressive agents. In the membranoproliferative glomerulonephritis, it is the disease which can be responded. It may be responded to the steroids in children, but not in adults. Actually, the hepatitis C virus associated mesangial cell membranoproliferative glomerulonephritis may improve with the successful anti-HCV therapy. If hepatitis C is chronic hepatitis C is there, along with this, you go for the specific therapy for the chronic hepatitis C. Again, the steroids role in the adults, it remains controversial. And rather than you go for the immunosuppression with the steroids, it's better have got results. Children is more, responded to the monotherapy with the steroids. In diabetes, you have to control the diabetes, you have to reduce the pressure, glomerular pressure, ACE inhibitors or ARB. So these are the management strategies in the nephrotic syndrome. Whatever I have said should be done like this. What are the essential of diagnosis? What are the etiology behind it? What is the presentation? And how about the investigation you have to do? And how about the management strategies are applied? So I'm very thankful to you for listening this short tutorial for the nephrotic syndrome. I have also discussed about the proteinuria. Remember my first part and try to remember that वो जो हैकी पैकी हो जाती है कि भाई शाम में जो है वो यूरिन आ रहे हैं, यूरिन के अंदर जो प्रोटीन आ रहा है, +1 आ रहा है, फलां आ रहा है, ये आ रहा है, और मुझे स्मेल आ रही है इसके अंदर, या मुझे इस तरह नहीं. यस, यू हैव टू डू द यूरिन एग्जामिनेशन. पर इसका एक ही तरीका है कि यूरिन एग्जामिनेशन शुड बी डन. यू आर ई फर्स्ट. अगर आप देखेंगे इसमें प्रोटीन यूरिया +3 है, तो उसमें जो है ना 24 आवर यूरिनरी प्रोटीन करा के देख लीजिए किस लेवल के प्रोटीन है. माइक्रो प्रोटीनूरिया है, मैक्रो प्रोटीनूरिया, फ्रैंक प्रोटीनूरिया, सब नेफ्रोटिक रेंज का है, नेफ्रोटिक रेंज का है. ये हम आपको मालूम चलाना है. प्रोटीनूरिया तो बहुत सारी कंडीशन में होता है. इसमें भी बिनाइन प्रोटीनूरिया, जैसे कि मैंने पहले बता दिया था. तो इतना वो यानी इस पर हंगामा मचाने की जरूरत नहीं. So I'm thankful to you for listening to this lecture. Inshallah we will meet again.